Cathy McNeill. Cathy, we're very happy to have your poster in our reception this year. And the name of Cathy's poster is Development of a Geriatric Functional Trauma Status Scoring System. And for short, we'll call that the GFTS. So that's a tool for measuring geriatric functional trauma status. Okay, great. Tell us a little bit about the background of this tool. Why did it occur to you that you needed to develop a GFTS?
Okay, well, as the population gets older, we know that they're living longer and they're more healthy, and so they're more prone to accidents because they're out there driving and doing activities. So when they get injured, of course, they don't have as much physiological reserve to bounce back from a trauma. So we wanted to help the caregivers and the providers and the families have some information to help them make informed decisions about what care they want to give their loved one. You know, what might they expect their loved one to be after they recover as much as they're going to from this trauma.
Okay. How did you go about starting to develop such a tool? And is there anything like that already exists?
There are a lot of scores out there, they're validated and everything, but none of them address the functional aspect. And we wanted to be able to tell, you, if your mother got injured, what she might be like afterwards. Is she going to be able to, take care of herself, activities of daily living, feed herself, that type of thing. So we wanted to look at all the scores that were out there and sort of marry them together.
Okay, what tools did you look at?
We looked at, a lot of them were physiological tools. They were looking at how type of brain injury they might have, their vital signs, looking at how they were injured, how badly they were injured when they came in. And one piece that was missing was the functionality piece pre-injury. We found that was missing, wasn't documented in the medical record, and nobody was really capturing that information.
Okay, so you're telling me that a person's function before they get, let's say, in a car accident, really is very predictive of what their function will be after the car accident or after they've recovered from whatever treatment they get for their accident,
yes,
right?
Their functionality post-trauma is based on their pre-functional status plus all the things that happen to them, the type of injury, the severity of injury, that type of thing.
Okay. So does the GFTS then only score the function, or does it include all of those factors you just mentioned, what happened to them during treatment and so forth?
It should encompass all of those because we took all of the scores. There's probably about 50 data points, but we just had a very small subset of people to do this retrospective study on, and so we weren't able to use all those variables. So we've sort of pared it down so we captured the most important things and looked at it there.
Okay, well tell us then about, first of all, anything else you did to develop the tool, and then how you used the tool with this small sample.
We actually were not able to develop the tool, but we found there were two very important missing pieces. One thing we looked at is there's a score that tells you the medication disease-based index, so it tells you whatever type of disease determines what kind of medications there are. So you could use that to factor in. That's a validated score. But it did not include anticoagulants that so many people are on nowadays, and really makes a big difference during trauma, rehabilitation. And like I said, also the piece of pre-functionality was not addressed anywhere consistently. So we knew those two pieces were going to need to be done. So we did the best we could, but we really just found that it's just a descriptive study, and we're really only able to find that we needed those two key pieces, and we plan to do a prospective study in the future, including those.
Okay, so your prospective study in the future literally is going to be a tool development study,
yes,
is that correct?
That's correct.
Okay, that's very exciting. With the results, with the 50 or so people that you got now, then, just to summarize, you discovered that what we are not doing now is capturing any information about pre-trauma functionality and What was the other?
The use of
And
anticoagulants.
Okay. And there was a problem with getting data on the use of anticoagulants, you found. Is that correct?
Yes, it's difficult. Nowadays, they have the prior to admission on the electronic medical record, so we can get at that piece, but we need to somehow fold that into the medication disease-based index, which does not include the use of anticoagulants because it was developed years ago. We did an extensive literature search with the pharmacy's help to see if there was something out there, and there's not.
Okay. All right, so your study then has uncovered really some gaps that we really do need to fill, and that's what you're going to be working on next.
That's right, that's right.
So what are your plans then for pulling this prospective study together?
Well, I guess the big thing is to write the protocol. We're in process of submitting the, preliminary data to a journal, and we're hoping that we'll be able to attract some funding then, because we will need some funding to do a prospective study. So we'll be working on the protocol for the prospective study in tandem with getting the article published.
Okay. Where have you sent your article?
We sent it to the Geriatric Trauma Journal, and they said it was interesting data, but perhaps it was not really a big-time study. So I think now we're going to go to some of I think the nursing journals would be far more interested in this. So that's where we plan to go.
Good. We will look for it.
Thank you.
Tell us when you get published. We will look for it.
All right. Thank you.
Okay. Thank you very much.
You're welcome. Thanks for letting me be a part of this.
And just to kind of fill in with this, let us know what you are doing, because I know over in trauma you're very, very busy with a lot of different studies, and I lose track of them sometimes. Just give us a little overview of what your role is in research in the trauma unit.
Okay. I serve really as a clinical nurse research coordinator, coordinating clinical trials, and some of them are industry-sponsored, some are investigator-initiated. We especially focus on traumatic brain injury because we have so much of that here and there's so much promise. Right now we're doing a very interesting trial with a drug that is sort of an insulin growth factor type drug for traumatic brain injury, and the goal is to hopefully protect those neuron cells, the brain cells, after the initial trauma, so there is no more secondary trauma. And then we look at people's status, and we do a neurological status at 1 month and 3 months after the accident, comparing them against themselves. And we've seen some dramatic, differences. We are blinded to the results, whether they got drug or not, but we have seen some wonderful promise in several patients.
Okay, good.
We're doing another traumatic brain injury study where we're looking at using something like a pulse oximeter for the brain and just putting it on there. So the hope is it will replace a patient having to go to CAT scan, which is very consuming of time and people and resources if they're in the ICU to drag them down to CAT scan. If we could put the little pulse oximeter on the brain on and tell about the bleeding, it would give us instant information, and we could do it continuously, that type of thing. And then we're going to be starting a study in January where we're going to be using tranexamic acid. It's a very old drug. It's for bleeding. It's been used first with hemophiliacs and also used more recently in hips and in knees to prevent bleeding during surgery. So we're going to be looking at that with traumatic brain injury. If a patient is in the field and the EMS come and pick them up, and they think they have a bad head injury, they're going to give an initial bolus, and then we will give them an 8-hour infusion once they hit the hospital. And again, we're looking at a neurological assessment down the line in 6 months and see how they're doing.
Okay. And of course, you'll probably use your GFTS on it.
That's right. Incorporate it all.
Good. Well, thank you very much, Cathy.
You're welcome.
Welcome to the reception. We're very pleased to have your poster
Thank you so much.
in our group today.
Okay. Thank you.